Fever is one of the commonest clinical conditions with pediatricians treat day in and day out. But managing a child with less than 90 days old with a fever without focus is a different cup of tea. And I'm focusing on conditions in which COVID-19 has been excluded by tests. If I include that also, it will become too much. And this is what has prompted me for this presentation is the American Academy of Pediatrics has come out with a new guideline. On the top of it, the Archives of Pediatrics has written editorials and new articles on this subject. Therefore, to keep you up to date and to see if our practice should be changed in a developing country like India, I put up this video. Now, my targeted audience is practicing doctors who look after children. This might be anybody in the ER doctor, the practicing pediatrician, or a GP. What I mean to say is that I am not, though the postgraduates may find this useful, if I start talking too much of theory, they need to have a much more theoretical based knowledge into which I will not go into because this presentation will become too lengthy. But but they will find this useful for them also. First, we will be looking at the theoretical aspects of this and later go on to the practical aspects of clinical practice. Some few introductory facts about this subject. The younger infants under 28 days of age are at higher risk of bacterial infection. This is very well known as below 90 days, below 28, they are at higher risk. No pattern of clinical feature or examination finding can be used to reliably predict the presence or absence of serious bacterial infection in this group. This forms the crux of the problem. Therefore, one might say that bedside medicine is important, etc. But the problem is below 90 days, it is well accepted that no pattern of clinical features or examination findings can reliably predict the presence of serious bacterial infection, which we are really concerned about. We don't want to miss that. The rates of serious bacterial infection are similar in UK, Europe, and USA, and between 10 to 20% for febrile young infants having a serious bacterial infection, the majority of which 9 to 17% will be having urinary infections, and 1 to 3% will be invasive bacterial infections such as meningitis and bacterial sepsis. Nowadays, they say that what we are interested in is the 1 to 3% of bacterial infections such as meningitis and sepsis. Therefore, out of 100 children which come to you with fever above 38 below 90 days, only 1 to 3 will have a serious invasive bacterial infection. And for this is what we are doing the whole function. Whatever we are doing is to detect this. At the same time, 10 to 20% can have serious urinary infection, which should be easily diagnosed by a urine examination. Therefore, the real issue is to detect this 1 to 3%. That's a crux of a subject here. The detection of fever below 4 weeks, the body temperature should be taken using an electronic thermometer placed in the axilla. These are things which are mentioned and these are facts which are mentioned in NICE guidelines. The electronic thermometer used abroad is usually this condition. I don't know whether you have the same one in your hospital. Beyond 4 weeks, beyond 1 month to 5 years, you can use electronic thermometer in the axilla, chemical dot thermometer in the axilla, or infrared thermometer. This is as per NICE guidelines. But the American Academy of Pediatrics insists on taking rectal temperature in children below 90 days. This is because your decisions of doing LP, doing lumbar puncture, doing giving prophylactic, giving IV antibiotic, admitting, everything depends on the temperature. This is something which I don't think is very practical in our circumstances, and we may be better off following the NICE guideline regarding this. Now, temperature elevation is a useful predictor of invasive bacterial infections when combined with other clinical features and laboratory-based inflammatory markers can improve the sensitivity to detect invasive bacterial infections. Now, generally, it is said that the height of the fever is not important in differentiating between viral and bacterial infections. But this is definitely true beyond 6 months. But below 6 months, the height of fever may be more, it is more pointing towards an invasive bacterial infection. In fact, a rectal thermometer temperature more than 40 degrees centigrade, 100 degrees Fahrenheit, hyperpyrexia is rare among febrile infants younger than 3 months, but is highly associated with invasive bacterial infection, not even serious bacterial invasion, invasive bacterial infection when it occurs. When you mean by invasive bacterial infection is meningitis or septicemia. Therefore, the height of the temperature is important below 3 months, may not be important above 6 months, and any fever lasts than more than 5 days in an infant. In present day practice, always think of Kawasaki disease. Now, immunization with conjugate pneumococcal vaccine has significantly decreased the rate of bacteremia in young infants and children, and in young infants it appears to both confer direct and herd immunity benefits. For management of children below 90 days with fever without focus has changed because of the changes that had occurred in the bacteriology as well as in the testing of the patients in this age group. If you look at the changes in bacteriology, since 1980s, the epidemiology of bacterial infection in neonates and infants has changed as a result of many factors, including prenatal GBS screening and incorporation of immunizations against streptococcal pneumonia. Now, GBS screening may not be very common in India, but generally group B streptococcus for generally considered by pediatricians as not a major threat in newborn sepsis, but it is not very well substantiated. Now, recent studies even in the West demonstrate that E. coli is now the most common organism to cause bacteremia. It is this leading to a second most common cause of bacterial meningitis in infants in 1 to 60 days. The E. coli has become the major pathogen, replacing group B streptococca even in the Western world. The shift from group B gram-positive to gram-negative predominance has implication in the choice of test, interpretation for values for decision making, and selection of antimicrobial drugs. We will come into that as we go into the next slides. Listeria monocytogenes is an important cause of bacterial meningitis, but its overall prevalence as a pathogen in febrile infants is becoming rare even in Western countries. This is because of the improvement in food hygiene. In India, the data are not very sufficient. There's general feeling that it's not so common. It's primarily isolated in neonates younger than 28 days of age and premature infants. The importance of listeria is the fact that it is not susceptible to third generation cephalosporins, and therefore when you are giving empirical antibiotics, you may have to add ampicillin if you have listeria, if you consider listeria as a probable pathogen in your particular place. Other potential etiologies in serious bacterial infections or invasive bacterial infections include Staphylococcus aureus, Streptococcus pneumonia, Salmonella species. If you have a newborn or a child below 90 days with diarrhea and blood in stool, you will have to think of Salmonella meningitis also. Enterococcus fecalis, Enterobacter cloaca, Moraxella catarrhalis, Klebsiella species, and Citrobacter species. The other thing which has impinged on our management is advances in testing. Inflammatory markers, the WBC, the absolute neutrophil count and the band count combined with clinical appearance and urine analysis has been the foundation of earlier clinical prediction models like Rochester model, Boston model, etc. With E. coli replacing group B streptococcus, that's the most common bacterial pathogen in this age group, these markers are no longer useful. They consider that the total WBC and the band cell especially are not that useful for E. coli gram-negative organism. C-reactive protein, an inflammatory marker produced by the liver in response to infections and numerous other conditions, is now available for point-of-care testing. Now, procalcitonin, expressed mainly in the thyroid C cells, is produced rapidly in response to infection and other tissue injuries, is more specific for bacterial infection than other inflammatory markers and rises more quickly to abnormal values. Each point of procalcitonin is very important. Mind you, this has been said in AAP clinical guidelines, which was published in August 2021. Therefore, they give a prime importance now for procalcitonin. I would say that procalcitonin has something like the same place as an MRI in head injury as far as screening for sepsis is concerned in a child below 90 days. This has become a very important investigation. Therefore, in places in which procalcitonin is available and the results are available within a specified period, it scores over CRP and ESR, etc. Because it rises rapidly, more specific for bacterial infection, and therefore that is why it is considered very, very significant to do procalcitonin. Now, in the pathogen identification also, there has been improvements allowing more accurate screening for invasive bacterial and more rapid and precise identification of bacterial, viral, and fungal pathogens. Automated blood culture systems can now identify most bacterial pathogens in 24 hours. It's available in private hospitals, but very, very highly costly. In India, costs somewhere near 900 rupees. Now, more recently, nested multiplex polymerase chain reaction testing for blood cultures can identify bacterial pathogens and antimicrobial resistant genes in approximately 1 hour. Not at all available as far as I am concerned. But more important than that, if you are doing a LP, multiplex meningoencephalitis panels can provide results in CSF for 14 potential CSF pathogens in 1 hour. Therefore, identification of the virus in the CSF is now possible with this. Again, of course, a very useful test, but it's very, very costly as well. In summary, although the viral testing should not affect entrance into the recommended pathways, for infants more than 28 days of age, it can be considered in individualizing evaluation and management decisions. The recommended pathways we will come into in the following slides. Now, if you take one example, for example, if you do a lumbar puncture and you get the CSF with neutrophils, but at the same time the gram stain comes negative, and if the CSF culture grows virus, especially enterococci, they say that you can send him home because enterococcal meningitis is known to cause polymorphonucleocytosis in the CSF. Therefore, big changes have come because when you do these advanced tests, if they are available, they are definitely helpful. A few words into the relevance of some of the well-known international guidelines, like the NICE, British Society of Antimicrobial Chemotherapy, and these 3 American guidelines, which are well known to us. In UK, there are 3 suggested approaches to the assessment and management of febrile infants. The NICE sepsis guideline, recognition, diagnosis, and early management guidance advises that all febrile infants under 3 months of age are treated irrespective of the age, clinical appearance, or laboratory features. While the more familiar guideline to us, the NICE fever under 5 assessment and initial management, advises a tailored approach with low-risk infants not requiring parenteral broad-spectrum antibiotic. The first one advises administration of a blanket administration of antibiotics for all children below 3 months with fever. Now, if you look at the third one, which is internationally well known, the British Society for Antimicrobial Chemotherapy, BSAC guidance that recommends that infants at low risk for serious bacterial infection may not require parenteral antibiotic. Therefore, the tailored approach of the NICE as the BSAC performed poorly when compared to the PICAN, which is Pediatric Emergency Applied Research Network, which is an American guideline and step-by-step guidance from the European guideline. Therefore, this statement that the NICE guidelines as well, both the UK guidelines perform poorly when compared to the American and the European guidelines is given in the varying international practices regarding evaluation of febrile infants in an editorial in the Archives of Pediatrics in March 2021. And the reason for this is the Pediatric Emergency Applied Research Network, PICAN clinical prediction rule and step-by-step approach have undergone multi-center validation, while the NICE guidelines have not undergone this. Therefore, when these NICE guidelines themselves say, when the Archives of Pediatrics itself says that the NICE guidelines are not as good, has not been validated as well as the American and the European guideline, we will not be discussing guidelines in further in this presentation. If these two British guidelines are to be used safely, then a period of observation or close follow-up in the community is required for those identified as lower risk. Unlike the American and the British in the European guideline, the NICE guidelines do not include the use of procalcitonin, as this is not widely available in UK and Ireland. This is the reason why uh, British guidelines do poorly when compared to the American and the European guidelines. Now in places therefore in hospitals in which you will be able to do procalcitonin, definitely it is better to use the British or the American guideline. But if you are in a government hospital or in some hospital where this is not available in real time, you may still use the NICE or the British guidelines. Now, when coming to well-known American guidelines, the specificity and strategy of identifying patients with serious bacterial infection in the Boston, Rochester, and Milwaukee guidelines are poor according to them. The large number of infants who do not have a bacterial infection are considered as high risk, receive broad spectrum antibiotic, and may be hospitalized. Several factors suggest that less aggressive approach to testing is reasonable in selected well-appearing infants at low risk of invasive bacterial infections who have an assured follow-up within 12 to 24 hours. This is given in up-to-date. Therefore, nowadays, even up-to-date, which mirrors the practice in America, are talking low of these well-known previous American guidelines. But remember, these guidelines are given in even the latest edition of Nelson's Textbook of Pediatrics, and postgraduates who appear for MD or examination may be better advised to know them in full detail. But I will not be dealing with them any further. Now it's coming to the practice, actually, the gist of the presentation. We would like to have some algorithms which will make our practice easy. We will base our practice mainly based on the new American guidelines as well as the European ones. The American guidelines have been published recently. In AAP Clinical Guideline Evaluation Management of Well-Appearing Infants 8 to 60 days old. They have taken up only up to 60 days from 8 days, not the newborn, and published as late as August 2021. Therefore, it's a very recent one. And we take the first block, which is 8 to 21 days. Previously, the block was below 28 days. Now it is 8 to 21 days. Remember, these studies are now, some modification is based on American Academy of Pediatric Guidelines based on the PECAN studies, which is Pediatric Emergency Care Applied Research Network studies, and the results are changed to some extent. Now, in these patients, you do a complete sepsis workup. A complete sepsis workup contains blood, inflammatory markers, blood culture, and a lumbar puncture. And when you do the lumbar puncture, you send it for HSV, that is herpes simplex viral infection, should be considered when there is maternal history of genital HSV lesions or fevers from 48 hours before to 48 hours after delivery. Therefore, maternal fever or immediate puerperal fever is an indication, and infants with vesicles, seizures, hypothermia, mucous membrane ulcers, CSF pleocytosis, in the absence of a positive gram stain result, leukopenia, thrombocytopenia, or elevated liver enzymes. In these conditions, you would send the CSF for PCR, HSV PCR also. And all these patients have to be given empirical antibiotics. But if you have suspect HSV also, then you have to give acyclovir also. Now, what are the inflammatory markers you do? You do procalcitonin, and it is considered high if it is more than 0.5, CRP more than 20, and absolute neutrophil count more than 4,000 to 5,200. Note here, they are not talking about the total leukocyte count or the band cells, which were there in the previous previous guidelines like Boston, etc., because they have not been possibly validated well. Now they add a rider here, which is little troublesome. Although we recommend infants in this age group have a complete sepsis workup, receive parental antibacterial agents, and be monitored in a hospital, knowing inflammatory markers results can potentially guide ongoing clinical disclosure. Therefore, they are telling, now we are telling all these patients should be admitted, all these people should receive IV antibiotic, they should have lumbar puncture. If the inflammatory markers are not high and you are sure you can follow up, you can make a different decision that you can follow up and then decide also in a well appearing child. But that is a second option which they are giving. Now coming to the next one, which is 22 to 28 days old babies. Now what they say is, what is the difference? We will look only at the, in the first one, in the sepsis workup, there seems to be no LP, and they are doing CBC and the inflammatory markers, etc. Now if there is abnormal inflammatory markers, you will do an LP. Therefore 8 to 21 days, you do a LP, whatever it is, that's what they advise. Here you do a lumbar puncture 21. This is a differentiation which they have made now, which was not there previously. And if there is a normal inflammatory markers, here also they make it a little vague, telling that you can do an LP or you need not do LP. This will depend on how the patient can be followed up, etc. But generally, if the 21 to 28 days sepsis workup, the inflammatory markers are not high, the child is not sick, you can avoid an LP. And whether you give antibiotics empirically is also positive and negative, you can avoid antibiotics. Therefore, the whole idea is somehow to not to be so aggressive as was practiced previously. Now coming to patients who are 28 to 60 days old. There's no LP, of course, in the first thing. And if the inflammatory markers are high, you may or may not do LP. If it is from 21 to 28, you will definitely do LP. Here, if the inflammatory markers are not high, you may or may not do LP. And if there is inflammatory markers are normal and the baby is 29 to 26 days, he is not looking sick, there is no indication to do a lumbar puncture. You can possibly give oral antibiotic. This is rather controversial. Now we will look at children between 61 and 90 days, that is 2 to 3 months. For this, we will have to look at up to date because American Academy of Pediatrics latest guidelines talks only below 60 days. And I'll only say the changes here. If the child has got clinically bronchiolitis or the RSV is positive, we would treat him as bronchiolitis. We would ignore the temperature. Therefore, he doesn't come under the algorithm even if the temperature is above 38. If the influenza testing is positive, we will treat it as influenza. If the child is 60 to 90 days. Now, below 28 days, even if these are positive, it is plus minus, you might err on the side of doing a complete sepsis workup, at least short of lumbar puncture, blood culture, and inflammatory markers. Another condition in which you would ignore the temperature is immunization within 48 hours in a well-appearing child. You might think of not doing a sepsis workup. I mean, you ignore the fever very much. But now this is an American guideline where they give the first shot of the immunization at 61 days or 2 months. Here we give at 6 weeks, which is 42 days. Therefore, they might be applicable above 42 days in Indian conditions, but there is no definite mention about it anywhere. Now, find out that above we are more conservative in the management. 61 to 90 days, no blood culture, inflammatory markers are done. Now, before I go on, I would like to make a few points. Now, we have many patients who come with COVID positive and have very high temperature. If the child is about 60 days, you can treat it as a well-appearing child. You can treat it as a COVID case. But if the child is below 28 days, you have to use your judgment and you might err on the doing a sepsis workup. If the child has been given antibiotic in the last 7 days, again, you may have to think of sepsis workup more. Fever more than 38 degrees centigrade, especially younger the child, the up-to-date says you have to move. The height of the temperature is important. Fever about 38 is what we are discussing all here. About 38.6, they say you have to consider doing a complete sepsis workup because it is more likely to be a bacterial infection. And many children may have diarrhea and otitis or otitis media. That does not, if you have a temperature high, you have to think of sepsis. Just because there is diarrhea, it doesn't mean that it is not a sepsis. It can still be sepsis. Otitis media can be accompanied by sepsis also. Here I would like to mention that urine test, if it is positive, we take it as UTI. But if the inflammatory markers are high, you must look at sepsis also. Because there is a higher incidence of children with sepsis in patients who have a UTI than in children who do not have a UTI. And this is correct if the child is younger. The more younger the child is. I hope you still have the habit of reading Nelson's test book of pediatrics. Even if you don't have, your examiners definitely will have and better know what is given in that. I am not going to go through this table completely. It just says the gist of this is if the child is between 2 and 24 months, that is less than 24 months, 2 and 24 months, non-toxic appearing or septic, it is non-septic, immunocompetent, no source of infection or risk factors for UTI, and is properly immunized, it just says supportive treatment. Remember, under this Nelson's test book, child is about 60 days, well-appearing child, immunocompetent, well immunized, no risk factors for UTI. They are not even advising any investigation, and they are not advising any treatment other than supportive treatment and probably only follow-up. Not even a complete blood count or a urine routine if you go through the algorithm. Now, many of you will consider me as unpatriotic if I don't quote from some Indian studies. In fact, there are very good Indian studies also. An evidence-based approach to evaluation management of the febrile child in the Indian Emergency Department. It published in 2018 in the International Journal of Critical Illness and Injury. I think almost the same article is published in the same article is published, if I am not mistaken, in the Indian Pediatrics. It's a joint venture of Indo-US Emergency and Trauma Cooperative Care. It must have been a very good, very well planned study. Now, if you look at this study carefully, what you see is we are only interested not in toxic in well-appearing children. They have classified children 28 days and less, 29 to 90 days, 91 to 2 years, and more than 2 years. This is the whole classification. They have not tried to make it 8 to 21, 21 to 28 to decrease the number of patients who require total septic care, etc. If I would say that this is published in 2018, and they will have to have a relook at it when things have changed so dramatically in 2021 as per the articles which have come in archives as well as the latest AAP guideline. The European guideline step-by-step approach is probably better suited for a condition because of its simplicity. It is actually advocated for 21 to 90 days, and it is the prospective study has been well validated, and it has a better sensitivity than the previous American guidelines, etc., to identify low-risk patients suitable for outpatient management. In this, you do only urine routine, procalcitonin, CRP, and absolute neutrophil count, the laboratory which we use, investigations. The total count, the band cells, etc., are not taken into consideration. Now, if the child is between 21, more than 21 days, between 21 and 90 days, is a well-appearing child, he has no leukocyturia in the urine, and the procalcitonin is less than 0.5 milligram per ml, and the CRP is less than 20 and the ANC is less than 10,000 per cubic millimeter, you classify him as a low risk patient and you can manage him as an outpatient with an observation in the ER for 6 hours. And I would rather advise in our condition to better observe him for 24 hours in the ward. Where you are doing something with the simple test that you are avoiding blood culture, you are avoiding IV antibiotics, you are avoiding invasive procedures like lumbar puncture. And the only thing is procalcitonin and CRP are a little costly, especially procalcitonin, and it should be available in real time. As per Europeans, they say it should be available in 60 minutes. At least it should be available in a few hours' time. If you are working in a hospital, if you want to bring quality to your care and avoid unnecessary investigation, I would say procalcitonin is something which you can invest your money on and probably advocate the patients to spend also. There are certain concerns regarding this. One is this is a flat for children between 21 and 90 days. Now between 21 and 28 days, the risk is higher for invasive bacterial infections. And there is a chance that you might miss this by 1%. 1% of patients who you follow this will continue to have invasive bacterial infections because you don't do a lumbar puncture. Now the other problem is in the intermediate risk group in which the CRP is high and the ANC is either the CRP or the ANC high. When the procalcitonin is normal, the Europeans wouldn't be interventional, but if you don't do a lumbar puncture, probably you miss about 3% of invasive bacterial diseases. But these are what is seen in studies in the ER, and probably better follow-up, as we come up in the following slides, would avoid this. Therefore, overall, I would say, in spite of some concerns, the step-by-step approach by the European Council, advocated by the European research, is better suited for our conditions. The contents of the next two slides took me by complete surprise. Now, this is an archives of disease childhood article in 2021. They state that the clinical performance accuracy appeared to confer better balance in sensitivity versus specificity trade-off than the national guideline. The overall sensitivity of clinical practice was 0.96, displaying a no significant difference from the most cautious guidelines. What they say is majority of the clinicians did not follow the guidelines very much, but their clinical performance was excellent. They had better sensitivity and specificity. This is never acknowledged in any article, but this is acknowledged by the Archives of Pediatrics. Despite this remarkable high sensitivity, clinicians managed to avoid administering parenteral antibiotic to all infants with a specificity of 0.27. This was significantly higher than any clinical practice guideline. Therefore, they avoided giving antibiotic. They picked up those children who required, the patients who required treatment also, and without following the guideline. Their results, the clinical performance of the doctors at the bedside was far better than what was done in the when you follow the guidelines. This is a statement which is never given in any other plan of management. The reason for this care are unknown and require further research. It is possible that clinicians were combining clinical experience with the underpinning principles provided by nice guidance. Therefore, for the first time, I have seen in recent years an articles acknowledging that clinical experience matters very much at the bedside, at least in this. Now, if you are telling that this is only done in the British guidelines, look at the American one. This is the AAP guideline again, 2021. In that it says, it acknowledges in studies of prediction model, the instances of missed invasive bacterial infections in well-appearing low-risk infants are rare. For infants not managed according to existing clinical prediction models, there are also rare misses reported in the literature. These factors suggested there's an opportunity to safely do less. Therefore, even when the clinicians don't follow this model, they rarely miss it. Clinical outcomes have not been shown to suffer despite non-adherence to contemporary standards of care. This is a very great statement. This is not a statement made in any other clinical guideline as far as I know, and this coming from straight from the American guideline itself. Now Nelson says, I think, gives a real reason. The protocol for ER visit is different from the office setting. In the ER visit, you may not, once you send the patient, you may not follow him up, especially in Western countries. This is not true in a country like India, where the pediatrician follows the patient rather than the patient following the pediatrician. In office setting, the management will vary because of the better follow-up. Therefore, what makes the difference is, in all these guidelines, how quickly you follow up is not given. It is assumed that you might maximum follow up within 24 hours. But in private practice as well as in general practice in most developing countries like India, the pediatrician is able to follow up within 3 hours, 4 hours, and you can be more liberal in your admission. You can admit the patient for keep him for 24 hours. In Western countries, this doesn't happen because of the problem of insurance, which objects to there's no admission beyond 6 hours for observation. Therefore, all these studies show, though there are the European guidelines is probably better, you need not rush and do lumbar puncture in a well-appearing child if you are ready to follow up very closely. But younger the child, be more careful. One common situation which we often face is the CSF is not unobtainable or uninterruptible. That means there is insufficient data to make a specific recommendation. Actually, there are no sufficient data about how to proceed from this. Evidence is not there. Options include observe without treatment for a period of time, and depending on the infant clinical condition, repeat the LP and laboratory markers. Here you have not obtained a CSF, therefore you can repeat it after 24-48 hours. That's what we normally do. Begin empirical antimicrobial agent and reassess in 24 hours on the basis of infant response and the results of blood culture. Now, the other problem that it often happens is a bloody CSF. There's nothing to be ashamed of. It happens even in 40 to 50% in well-known Western countries also, Western Children's Hospital also. If CSF is bloody or antimicrobial agents have been previously started, analysis by multiplex PCR can add additional information. Consult with a local pediatric infectious disease specialist. I don't know how he is going to help. The thing is that what they don't advise is that many times we make a calculation based on the RBC count and the ratio of the RBC count to the WBC count, etc. They say this is not advisable. Therefore, if there is a bloody, it is better to do a multiplex PCR. Now, this multiplex PCR, especially viral PCR, can be useful in another context also. Sometimes you do a lumbar puncture, you get CSF pleocytosis, the gram stain comes negative as well as the CSF culture and the blood culture. In these patients, if the enterovirus comes positive, then you can safely send the patient home, because enterovirus meningitis are known to produce pleocytosis with neutrophils. After the lumbar puncture, normally we start them on third generation cephalosporins, which are cefotaxime or ceftriaxone, should be used when parental antibiotics are indicated. Ceftriaxone is probably avoided in neonates because of its property of displacing the bilirubin. For infants less than 3 months, antibiotic active against listeria should be added. This is a matter of policy which you have to take in your hospitals if you think listeria is of concern. Intravenous acyclovir should be considered for children with fever and any of the following when you are awaiting the herpes PCR and the CSF. If there are focal neurological signs, focal seizures, and reduced level of consciousness. This is a very important point. most of the patients will have a certain amount of reduced level of consciousness. Therefore, there might be a candidate for giving empirical acyclovir till we get the LP lumbar puncture results for PCR. In communities with circulation of E. coli strain that produce extended spectrum beta-lactamase, gentamicin should be used instead of ceftazidime for the treatment of suspected bacteremia or sepsis. Little surprised by this statement from the American Academy of Pediatrics, but if you have meningitis, then meropenem should be used instead of ceftazidime when meningitis is suspected. Use of 4th and 5th generation cephalosporins may also be considered with expert consultation. Summarizing, we would like to use the step-by-step approach for this, but you have to keep in mind certain points which I will allude to in the next slide, that is concerns. Therefore, in the next slide, I summarize the whole presentation. For reasons already described, the best practice, probably the best, would be the one step-by-step approach of the European guidelines, European studies. Mind you, this is for 21 to 90 days, but you should know some of the problems with it or some of the issues with this. 21 to 90 days. Now, there is concern that between 21 and 28, not doing a lumbar puncture, here we are doing PCT, CRP, and urine routine and ANC alone, may be a little risk. You have to keep it in mind. And as per AAP guidelines, 8 to 21 days, you have to do a lumbar puncture in most of all the patients. Therefore, 8 to 21, the guideline, you cannot follow the step-by-step approach. The other problem, while it is conservative in the management between 21 to 28 days, it seems to be over intrusive above 60 days. Above 60 days, the step-by-step approach asks for procalcitonin, CRP, etc., which are really costly. The specific guideline which gives about 60 to 90 days in the up-to-date does not have blood culture or inflammatory markers. Nor does it talk of procalcitonin or CRP. It only talks of urine analysis. Therefore, if you look at even the American guidelines, the step-by-step approach between 60 and 90 days seems to be investigating more than is necessary. If you follow even the Nelson's textbook of pediatrics, in a 2 to 24 months, that means about 60 days to 24 months, non-toxic appearing, immunocompetent, where there's no source of infection or risk factors for UTI, and the child is completely immunized, only supportive treatment is advised. No investigation is advised. For these things you have to keep in mind. The step-by-step approach is no doubt the best, but it seems to be under investigating in 21 to 28 days. Below 21 days, it is not applicable. Above 60 days, it seems to be over investigating. But at the end of the day, one size does not fit all. Definitely in fever management below 90 days. The best would probably be step-by-step approach, but you will have to individualize the care based on follow-up. If you are following up carefully and you think that the parents are responsible patients who would listen to you, you can probably manage them, more of them, by observation and not by strictly doing all the investigations like lumbar puncture, blood culture, and giving empirical antibiotic. But whatever practice you do, you have to have a sound theoretical practice, theoretical knowledge, and your practice should be backed by published data. With this, we come to the end of the presentation, and thank you very much if you have listened so long. My other videos, educational videos, will be found in this YouTube channel, and I also blog on wordpresses.com on pediatric topics. Thank you very much.